This is Caleb from the National Rural Health Resource Center and the TASC team. This is our February TASC 90 webinar, where we will hear from our partner organizations, the Federal Office of Rural Health Policy, ARCITA, the Flex Monitoring Team, and then we have Rhonda Barkas from the center here today to talk about the recommendation and adoption progress interview and appreciative inquiry. And we want to bring that to you guys as an opportunity to provide another resource that might be beneficial to your Flex program. And we thought it would be timely as you're writing your competitive cooperative agreement applications. If we don't have any questions before I get started, I will go ahead and provide some of the task updates. Again, star 2 will unmute your line. We are currently receiving applications for the reverse site visit breakout sessions. So we have a proposal process. If you'd like to participate in the reverse site visit and speak at a breakout session, please respond to the request for proposals that Nicole has sent out, and I'm sure we will be sending out reminders. And if you're interested and have not seen that, please reach out to anyone at the TASC, at TASC or at task@ruralcenter.org, and we will be happy to answer any questions you have regarding that. Speaking of the Flex Cooperative Agreement Notice of Funding Opportunity, TASC is able to review one of your sections of your cooperative agreement applications. So if you'd like us to review your work plan or your narrative, please go ahead and send those along to us, and we will provide feedback regarding your application. We're not able to make any edits to it, but we are able to provide feedback. And there are emails out about that as well. Nicole, can you remind me of the deadline for that? I believe it's the 15th of March to get those to us?
It is, yes, March 15th.
March 15th is the deadline to send those over to us.
Yep, and then allow us 5 business days. Yep. Correct.
And on that, another reminder for your notice of funding opportunity, Flex Cooperative Agreement application. The December virtual knowledge group call had a bunch of tips and tricks and best practices for writing an application and ensuring that your application is sound when you review all of the aspects of the application. So please please remember that as you're preparing your application. The March Virtual Knowledge Group call is going to focus on COMPASS, the Critical Access Hospital Critical Access Hospital Measurement Performance Assessment System. And we will be sending out some information about that. The thought now is to have a working webinar. We want to hear from you guys. The Flex monitoring team wants to hear from you guys regarding COMPASS and how it can be improved to make it as beneficial and meaningful to you guys as Flex coordinators as it can be. Let me make sure I'm not forgetting anything else. Oh, NOSOR, the National Organization for State Offices of Rural Health, has a draft of the 2019 Rural and Frontier EMS 3-year National Tactical Plan posted for comment. This document has been a cooperative effort with the Joint Committee on Rural Emergency Care, JCREC, the National Association of State EMS Officials, NACIMO, NOSOR, TASC, and the National Association of EMS Physicians, and proposes a 3-year tactical approach to implementing some of the most important feasible recommendations from the 2004 Rural and Frontier EMS Agenda for the future. If you have an interest in EMS, this is an opportunity to provide feedback on the document that will guide rural EMS work for the next 3 years. Comments are due by February 22nd, and more information is available on NOSOR's website. Another couple things from TASC, just a couple updates on some of the projects that we're working on. I am engaged in efforts related to COPD, the chronic obstructive pulmonary disease, and efforts surrounding that. So we're working on a manual or a guide for Flex coordinators to share with hospitals surrounding COPD efforts and how hospitals might benefit from integrating COPD or pulmonary services into their hospitals, how, things to think about, billing and coding, expansion of services, the importance of the incidence rates of COPD, things to that nature. We're also working on a podcast series about COPD, and the topics of that will be similar: the importance of it, the incidence rates of COPD, treatment options, where to go for resources and assistance regarding implementation of COPD or pulmonary resources for hospitals. What else am I forgetting? A couple other things related to COPD. So if you have any questions about that or interested in pulmonary pulmonary services or COPD specifically, please don't hesitate to reach out to myself. And Nicole has a bunch of EMS work that she's working on, so I will let her talk to you about that.
Yeah, so supplemental work that we at TASC are doing this year related to EMS includes the creation of an online self-assessment for EMS providers to take to gauge their readiness for value and population health. Once they fill that out, they would get an automated response from our website that would include some information about their current status and some resources on how they might move forward. We are working with NSTEM, so also for the creation of that. We are working on a guide about EMS regionalization, so some thoughts on what regionalization is, what it isn't, what it can and can't do, and some examples of that. So we're expecting those two things to be done by the time the reverse site visit rolls around this summer, so that we can be talking about those and looking at them. We are going to be doing wrap interviews with a few of the flex programs that are doing EMS supplemental work, the FY18 supplements. There were 37 or so of those programs, and out of those we'll be talking to a bunch of them to gauge how those programs are going and kind of help us look at some best practices and see what we might share. We also plan to do some video spotlights about EMS projects this year, so that will come a little bit later in our program year. And the last thing I would mention is that we are going to be hosting a small group meeting in March on rural emergency care integration. So we are gathering some stakeholders, including flex programs and state offices and some consultants and others, critical access hospitals, ambulance providers, of course, to look at what the issues are between EMS and hospitals and think about some ways to address them and identify resources and ideas and ways that flex programs could support those efforts. And that's it for me. Thanks, Caleb.
Thank you very much, Nicole. Sarah Young from the Federal Office of Rural Health Policy, are you on?
I am here as soon as I can find my mute button, Caleb.
Good afternoon.
Good afternoon. I had a few updates from our policy team to share with this group. In the last quarter, the let's see, can you actually go back a slide, Caleb? There we go. In the last quarter, the final rule that is likely to be of most interest to state flex programs and cause is the update to the Medicare Shared Savings Program and Accountable Care Organization, or ACO program, that was published at the end of December. For people to know, this final rule redesigned the Medicare Shared Savings Program, which is now referred to as Pathways to Success, and increases the requirements for accountable care organizations to take on greater risk and greater reward contracts with Medicare, and that includes downside risk. The program, ACO, the next version of the ACO program will have a basic track, which is 2 years with no downside risk and 3 years with phased-in two-sided risk, or an enhanced track with 5 years of two-sided risk. And something that we've definitely heard from rural stakeholders, including many of you, is concerns that requiring two-sided risk may make it difficult for rural hospitals and other rural healthcare organizations to participate in ACOs. So it is certainly something that our policy team is monitoring closely and is very interested in your feedback on. There were a number of other changes listed on this slide I won't read to the ACO program, also in that proposed rule. And as a reminder, these policy updates that we recap on the TASC 90s were, of course, came out first in the weekly announcements from the Federal Office of Rural Health Policy. So if you want to get more up-to-the-minute policy announcements, please do sign up to that mailing list if you aren't there already. If you'd quickly switch to the next slide. Nicole made me a presenter, so I can switch myself. Just as a FYI, there was a proposed rule that the comments recently closed on for changing some of the regulations around Medicaid and Children's Health Insurance Plan managed care programs in the states. And one thing our policy team called out that may be of interest to rural stakeholders, and that was some of the proposals around changing network adequacy standards. And there were 2 recent requests for comments and information published by HHS that comments on both of these closed earlier in January, again, or possibly February. Anyway, again, if you want timely updates on these things, please watch the weekly announcements. But just so you know, HHS is requesting comments on strategies for, or has requested comments on strategies for reducing burden related to the use of health IT and electronic health records, and on suggestions for modifying HIPAA rules to improve coordinated care. And as always, you can reach out to the FORP policy team at ruralpolicy@hrsa.gov if you have questions or experiences to share that relate to Medicare rules and regulations and other HHS regulations, or if you want to know more about any of these policies and rules. Are there any questions about the policy updates?
*2 will unmute your line. All right, hearing none. Sarah Young, if you're ready to let Sarah Brinkman from Stratus Health and Arquita provide their updates, we will hear from Arquita.
Great, thanks, Caleb. So this is Sarah Brinkman from the Rural Quality Improvement Technical Assistance Center, our Arquita team at Stratus Health. I just have a few quick updates for you all. So hopefully you have on your calendars, we have an MD-Quip virtual knowledge group call coming up next Thursday, February 21st from 2 to 3:30 Central Time. The primary focus of that call is going to be around antibiotic stewardship, so we'll be getting some data updates, hearing from the Federal Office of Rural Health Policy regarding some clarification on expectations around implementation of antibiotic stewardship and the tracking of that. We'll also be talking about some strategies for engaging and supporting hospitals with antibiotic stewardship implementation, including leveraging, potentially leveraging SHIP funds, hearing an example from one of your peers around what they're doing and trying to drive some discussion around that. And then we'll have some time to talk about how you all are organizing and thinking about the quality portion of your NOFO application. On that note, we do want to throw out, oh, yeah.
Sure, this is Nancy Jo. Hi. Are you guys going to send out another invite for that? I don't have it on my calendar.
Sure, I can send a reminder out. We don't send out an invite, we send out a flyer that has all of the dates for the year, and you can register for all of them at once. So,
all right, yeah, I missed that. I apologize.
That's okay. I can send that again.
Thank you.
Thanks for asking. With regards to the NOFO preparations that you're all doing and writing that you're doing, just want to throw out there that the Arquita team is available if you want to bounce some ideas in terms of how you are working and organizing yourself to around the quality portion of your application. If you'd like to run any ideas past us or get some insights, we're open to that. Feel free to send us an email to request that. With regard, another topic on antibiotic stewardship, and we'll talk about this on the virtual knowledge group call next week, but we are going to be working towards convening some focus groups with critical access hospitals nationally that are doing well with their implementation of antibiotic stewardship based on their National Healthcare Safety Network or NHSN annual facility survey responses. So we'll be hoping to coordinate that with all of you in terms of outreaching to those hospitals and helping to get them engaged in those focus groups, and then developing a resource out of those focus groups to help inform what critical access hospitals can do, and then also to serve as a resource for all of you as you're supporting them in that effort. We've had a few resource updates recently. They've been highlighted in our distribution of MD Equipment Monthly as well as an MD Equipment Monthly itself. So as measures continue to change or as the time frames for those measures start to fall off, you'll see some updates from us around some of the standard resources that are most utilized, things like the data submission deadlines, the quality reporting guide will be updated here shortly, other resources that reference the measures specifically are all in the process of being updated or have been updated. So just keep your eyes open for those. If you have any questions about where an update stands, don't hesitate to reach out. We're happy to speak to that. And I think that pretty much covers what we've got currently, and we look forward hopefully to seeing most of you next week. I will get a reminder email out to the group today with the flyer for the registration for the BKGs for the course of 2019.
Great. Thank you very much, Sarah. Any questions for Sarah or the Arquita team? *2 will unmute your line. Hearing none, we can transition to the Flex Monitoring Team update. John, are you on? Or a representative from the Flex Monitoring Team. *2 will unmute your line.
Hi, if John's not on the line, this is Mariah Quick from the University of Minnesota. I could give a quick update.
That'd be great, Mariah. Thank you very much. Welcome.
Yeah, no problem. So in January, we finished our annual HCAHPS reports. So the national and state reports are available on the Flex Monitoring Team's website. And we anticipate getting our Hospital Compare annual quality measure reports done in March. There was a little delay in receiving the data. Usually we get it in December or January, and it's still not available from CMS. So they're a little later than usual, but they're coming. We had 2 briefing papers come out of the University of Southern Maine, and those are available on our website as well. One is on community benefit activities, and the other is on community needs, health needs assessments and implementation plans. We have a couple other papers in the works that are going through final edits and formatting. So those, once they're done, will be disseminated through our Flex Monitoring Team listserv. So if you're not on our email chain, you can sign up on the Flex Monitoring Team website for immediate releases and updates on our data. And the other big thing is we're continuing to work on our Compass system, which is the system that lets CEOs and CFOs as well as state Flex coordinators look at data in the different Flex program areas of quality, community, and financial. So right now we are working on making the quality and the community data publicly available so that you won't have to sign in as you do right now to access the data. Financial will still have a sign in, but we're hoping to do some beta testing on that in late spring and have that up and running by probably, hopefully, April or May. I think that's the main updates. So if anyone has any questions, hopefully I can answer them.
Great. Thank you very much. Any questions for the Flex monitoring team? Star 2 will unmute your line. All right. Hearing none, I will introduce Rhonda Barkas from the center. She's a program manager with the center with a background in, I'm drawing a blank here, Rhonda, but she helped develop and create the recommendation adoption progress interview that the center has been utilizing for evaluation purposes for a number of years now, and we asked Rhonda to present on this webinar as an opportunity to share the RAP process with more Flex coordinators, as we at TASC, as well as some of the other Flex coordinators who we have coached up on this, find it pretty beneficial in our efforts, and we thought it would be a useful tool for Flex coordinators, especially now as you're beginning to write your cooperative agreement applications. So without any further introduction, Rhonda, are you on? Star 2 will unmute your line.
Yeah, can you hear me, Caleb?
I can. Thank you for joining us.
Oh, absolutely. Thanks for having me. I am really excited to be presenting to you guys today on RAP. As Caleb was sharing, we started RAP with an RHPI project several years ago. You guys might be familiar with that. It was the Rural Hospital Performance Improvement Project that was in the Delta states. And just a little bit of background about that. So my background is in behavioral health. I was an alcohol and drug therapist for years, and then later moved into doing organizational and leadership development. And so when I joined the center and started working with RHPI, I was brought on specifically to look at and develop a system for being able to evaluate how our projects were going, because our RHPI, a lot of those projects were about $30,000 projects. We were supporting almost 30 projects a year, and so we really wanted to make sure that that was money well spent and that people were utilizing the recommendations from the consultants. And so was brought on to start looking at how we might do that. And since my background's in behavioral health and organizational development, I just happen to have a preference for actually talking to people. And imagine that. And so when we started talking about how we were going to really collect outcomes, I just felt real strongly people did not want one more survey to fill out. That surveys were fine in their place, but it wasn't going to give us the really rich information that we needed. And so that's when we created the RAP process. And I will tell you that the RAP process, and you're going to hear me say this frequently throughout this presentation, it is very simple, but it's not easy. And I think that's part of the issue, is that a lot of times people will see that, oh, it's 4 questions. That simple. All I've got to do is ask these questions. So what I'm going to talk about today is, I'll mention the 4 questions that you use, but I'm going to really dive more into how you make the most of those questions, how to handle different issues that might come up, and how to make this not an interview. And you'll again hear me say that frequently, that this is not an interview. It's meant to be a conversation, and that's what makes it really rich, is when you're able to really use this as a conversation. So that's why I love talking about this. So the focus is really going to be on the art of using RAP, not on the science of it. But I will give you a little bit of background first. The other thing I will say up front is that my PowerPoint is a little word heavy, but I'm not the kind of presenter who reads the words, and so really I want the PowerPoint just to be a tool for you later, so that if you decide to use RAP, you could pull up this PowerPoint and kind of go through, and it will jog your memory on some of the things that we talk about. Okay, so the center. So here's the agenda for today. Talk a little bit about the overview, how we use RAP at the center, the science of it, the art of it, and then some questions. And I think that this saying over on the side encompasses really nicely the difference between the art and the science, that this is really about speaking in a way that people want to listen, but then it's also about listening in a way that other people want to speak. So I will get more into that in a moment. So again, it was created in 2010 with the Rural RHPI project. And the RAP questions, again, and I know that I will say this at least one more time, is that it's meant to be an interactive conversation, not an interview. So if you think about it, if I were going to interview somebody, I would say, so what's going well? Well, what's your next steps? What are you doing after that? So we don't want it to be an interview where it is a one-sided conversation. It really needs to be a conversation where I ask something, but then I listen, and then I'm responding to what they say to dig a little bit deeper. So again, the richness and the beauty comes from not the questions, but how we finesse them and how we dig deeper into the questions. So some uses of the RAP interview. So the RAP interview itself is the conversation I have somebody with them about their project and what they've been doing on the project. At the center, we take the RAP conversation, but then we also do collect measurable outcomes. That's important. And we pull the story, which is the RAP conversation, together with the measurable outcomes to tell the whole story about their project implementation. I have found over and over again that a real good RAP interview actually energizes and re-engages hospitals. I've had conversations where folks will say, oh, I didn't realize we had done so much, or now that we've talked about everything we've done, I'm excited to get going again. So that, and I hear that over and over again. I'll also say that over the years, it used to be I would do these with just the CEO of the hospital, and now more and more CEOs are also including their leadership team in this conversation, because again, it is such a rich opportunity to re-energize the team that worked on a project. We also use the RAP interview just to be able to identify success stories, and I'll show you how we use that in just a moment. We sometimes will use pieces of that for testimonials, and I'll mention that later. We also use the RAP interview along with our measurable outcomes to work with an economist out of Michigan, and he does a return on community investment for our programs, and he uses the RAP interview information for that. And the nice thing about the RAP interview is that it's 4 basic questions, but with a little bit of tweaking, you can use it with almost any program, any project, anything that you're really wanting to dig deeper into to see how the outcomes are going. So here's an example of how we use the RAP with the Small Rural Hospital Transition Project. That's one of the main projects that I work on. So we use after I do the RAP interviews, we actually create hospital spotlights from that RAP interview. From the hospital spotlights, we put those in our newsletter and on our website. And then we also have created our spotlight videos from that RAP interview. So again, that's the way that the RAP interview comes to life. So it's not just a conversation on paper, but it really comes to life so that we can really illustrate the outcomes from our program and be able to show value. And that's what we know that we all need to be able to do. We need to be able to say, hey, this funding for this project or program shows value. So very briefly on this, the RAP philosophy was actually based very loosely on appreciative inquiry. And I say very loosely because, you know, when I was working in organizational development, we used appreciative inquiry to be able to address change management, for instance, in different departments. This is, at that time, that was about 15 years ago, at that time it was really new to even use this in a hospital because people were so used to the medical model. The medical model is tell me what's wrong, tell me what's not going right, tell me what we need to work on, which is, you know, how medicine used to be, instead of really looking at strengths. And so appreciative inquiry is much more focused on the strengths, what's going on well, and what can we really capitalize on to keep going. And again, the actual AI has 4 cycles, and RAP is just very basically loose, very loosely based on that. So here are the RAP questions. The first 4 are the ones that we use probably with all of our projects and programs. Basically on a scale of 1 to 5, the extent to which the hospitals implemented the recommendations, what's going well, what are the next steps, and how's it impacting your culture. Those first 4 questions are the basic questions. Questions 5 and 6, those are the specific ones we use with the Small Rural Hospital Transition Project. You know, our goal in the SHIRT project is to help hospitals move towards value-based systems and prepare for population health. So we always ask them that question. And then we also ask them about how our learning collaborative and how that supported them. But I'll talk a little bit more about that later. So those are the questions. That's the science. That's the basics. But again, there's not a lot of value in me just sitting down with somebody and saying, so on a scale of 1 to 5, to what extent have you implemented the recommendations? What's going well? What are your next steps? I mean, because I'm just going to probably get 1 or 2 word answers or a few sentences, but most of the RAPs that I do actually will last at least 30 minutes. Sometimes they even will go an hour because folks are really making this into an effective conversation. So the effectiveness really comes from that conversation. So I think, so as we move into the art of this, the first part that I must always do is to really set the stage that this is a, you know, very warm, non-threatening discussion. So I don't say, okay, I'm going to interview about your progress on this program. I mean, I really make sure that I'm very open and welcoming, and I'll talk about that in just a little bit. It's really important to listen to what is said, but also what is not said, and I'll mention that in just a moment. You got to be really engaged in the conversation. This is not where I can let my mind wander. I have to be listening. People like to do it differently. I like to take my own notes while they're talking, because that helps me to really grab onto what they're saying so that I can think about my next question. You got to know when to dig deeper and ask for details and not adopt an interview-like tone. So the art of just setting the stage, and I will say that up here I have in quotes, please know that I do not script any of this, so this is not meant for any of you to even script it. This is just kind of a suggestion on how I might say it. So the first thing in setting the stage, I always let people know what about the process. I always say something about, I sent you the questions up front. We're just going to go through those questions, but it's just kind of a guide for our conversation. I'm going to be taking lots of notes while you talk. Might stop you every now and then to dig deeper. Also, the other thing, that second bullet, I think is important with at least SHRP projects and a lot of the projects we support. It's not a 3-month thing. It's a year's time. So with the first wrap call, I always let people know the project's big. It may take you 1 to 2 years to really implement. This call is not to talk about what you didn't do, but really to talk about your successes and what you have been doing so far. So that just saying that tends to take away, I think, that defensiveness, because when people are having a conversation about how they use funds or how they implemented a project, a lot of times they're thinking about what they didn't do, and there's that fear of having to say, you know what, we haven't done everything. That's okay, because we really want to focus on what they have done. And then I always ask them any questions before we start. The first question, this sets the tone, and people have asked me, do you always use this as the first question? Yes, I do, because it sets the tone. So on a scale of 1 to 5, to what extent have you all implemented the recommendations of the consultant? Up here, just for you all to know, I have what 1 means all the way through 5. We use that scale specifically for a program. We're doing wrap calls with, we're doing a project for Minnesota, the integrating behavioral health into primary care. So we do quarterly calls for 1 year with all of the hospitals that participated. So this is kind of the scale I use to explain to them what a 1 might mean, and a 2 might mean, and a 3 might mean. With the SHRP project, I don't give them this kind of scale. I just say on a scale of 1 to 5, a 1 meaning nothing's been done, a 5 meaning everything's been done. Where do you feel like you guys are right now? And it's okay to give half a number, so if it's 2.5 or 3.25, that's fine. So I asked them that question, and if they're the kind of person who wants to try to figure out scientifically what the right answer is, I always just tell them, there's not, I don't need any data to support this. I just want to get a sense of where you feel like you are right now. So, I might get a 2, a 3, or 4, and that's a really important thing for me to keep in mind, because as that next bullet point says, this creates the framework for everything else that follows. Because if somebody tells me, oh gosh, we probably were at a 2, then I know in my mind what to expect as I go through the rest of the questions. If somebody says, oh, we're at a 5, then that sets a tone for what I should be able to expect. So this helps me to think about how I'm going to craft the questions and how much further I'm going to dig. So let me go to question 2 so I can explain that a little bit more. So the second question, again, I don't read this to them. Usually I just say, so what's going well? Tell me what you feel proud about. What kinds of things have you guys implemented? And this question is usually the meat of the conversation. It's the one we spend most of the time on discussing. And this is where it's really important to think about what was that RAP score as I'm digging into this question. So their responses should validate the RAP score. If it doesn't, that's a red flag that I need to really dig further. So I can give you a couple of examples of this. I did a call with a CFO and a CEO, and they told me that on their project they were at a 4. And I said, oh, great, so tell me what's going well. And they were like, let's see. And then they started giving me really vague answers. You know, if somebody gives me a 4, they should have some really specific things to say, oh my gosh, we've done this and this and this and this and this, and this is what we're seeing, and we're so excited. So they couldn't give me a lot of detail. And so I kept digging. And I said, well, I know that you guys were going to implement point of service collection. How's that going? Well, you know, that's going pretty good. Oh, really? Well, what did you do? How did you teach the staff how to do that? Well, you know, and they kept avoiding my questions, even though they gave me a 4. They couldn't give me any specifics about what was going well. Finally, and usually this will happen, finally they said, you know what, we got to admit we haven't done much with this project at all. We've had other things on our plate, and we just haven't implemented a lot. I really appreciate knowing that. And so I was able to say, thank you for telling me that, because then we could kind of see where did they get off track. And by the end of the conversation, their next steps were they were going to pull that team back together and refocus. I happened to be doing another wrap with them in 6 more months, and so I said, oh, I can't wait for the next 6 months to hear what you've done. Sure enough, when I called them back, they had implemented. So that's why it's important to be able to listen, as I said, to what's being said but what's not being said. If I had just gone with, oh, a 4, oh, we implemented this, and I didn't listen to kind of the undertones of what they were not saying and what they were trying not to say, we would have not really had a successful outcome from that call. So these are some examples about how I will dig down a little bit more. You know, gosh, I know you guys were doing bedside report. How did you do it? How's it going? A lot of hospitals have a hard time with staff compliance on bedside report. How are you guys making that happen? Tell me more about your later rounds. So that's when I will be more specific and point to some of the things that I knew that they were going to do. Otherwise, I try to leave it broad and let them just start telling me. Some more suggestions for finessing this question. Again, listening for those diversionary tactics. One thing I do hear sometimes is a team, if they're trying not to answer my questions, they will start talking about things that have nothing to do with the project, or they'll start talking about the state of politics now. You know, they'll go off into something else like that, and that's usually a sign they're trying to not talk about their project. And so I very politely stop them, and I'll say, you know, say something like, you know, I really want to hear more about that bedside report. Let's go back to that. Tell me more about that. So I do stop people as soon as they take a breath, and we'll dig down a little bit deeper into some other topics. And again, usually after I've done that a time or two, if they haven't done a lot of the work with it, they'll let me know that. The other thing that's really important with this question is I always reinforce great work. And I will often let people know, you know, I am just in awe of all the work you've done, because one of the things that often comes out in these rapid interviews is people have done more work than they realize, and that's why I try to dig down into some of the details. So if they implemented point of service collection, I don't just let them say, oh, we implemented point of service collection. I'll ask them, so what, how'd you do that? And then they're telling me about how they had to do scripting, how they did the training with the staff, how they did this, how they, you know, so they tell me, and I was like, wow, that was a lot of work, because I want them to walk away feeling proud of all that work that they did. When they finish talking about their successes, I always ask again, so what else is going well? And sometimes I will say that if they've already talked about so much, then I'll say, gosh, I'm almost embarrassed to even ask you this, but anything else? And then they'll start laughing, and usually they think of something else. The other thing then is to allow silence to happen, because sometimes they're thinking, and a lot of us are uncomfortable with silence, and we want to rush into it. So I just sit there quietly and let them either be uncomfortable with the silence or use it to think. And then again, if there are some things that were pretty big on their action plan they didn't mention, then I might go back to it and mention, yeah, I know you guys were working on swing bed. What have you done with that? And then sometimes they'll say, oh yeah, I forgot to tell you about that. Or sometimes they'll say, you know what, we are putting that off till later. Okay, that's not a problem. All right, question 3 is asking them about the next steps. If they, usually when people are talking about what they have done, they will often go ahead and mention, oh, and next we're going to do so-and-so. I make sure I go ahead and jot that down so that I can come back to it and say, yeah, let me hear about what your next steps are. I know you mentioned that you guys are going to kick off so-and-so. Tell me your thoughts about that. So, because I want them to know that I'm listening and that I'm not saying, so what are your next steps, when they've already told me 5 of them. So I try to remember that and reference it. And again, if there was something important on their action plan they didn't mention, then I might mention it. I know you were going to work on recruiting your PCPs. What are your plans about that? And then I will say that if this is one of those interviews where very little has been done, we've had a conversation, very little's been done, this is usually when people say, you know what, we need to refocus on this. And if that's what they say, I will again say absolutely that the report is still valid. Please do let me know how we can help you. Follow up with you in 3 months and hear what you've been doing. And usually people do. Aside from the measurable outcomes, what are ways the project impacted your hospital, the culture, your community? This question, I think, is so important, and yet I think we sometimes miss why it's important. So I always tell folks why I think this is important. I always say a little something to them that, you know, measurable outcomes absolutely are important, but the way projects impacted your community or your hospital, that's going to speak to sustainability. Because we all know that sometimes people will work on a project, they get good measurable outcomes. The minute we stop paying attention, the measurable outcomes go back to where they were before. When you have a culture change, that's when you have true change. And so I want to know what kinds of things in their organization have changed, because that's going to support that sustainability. And so often they will name things like, you know what, our leaders are working together in ways they never have. Our staff really get are on board with patient experience and are excited to be doing moments of kindness for their patients. Or morale is better. There's less silos. We are sharing more information with each other. Because again, those are the things that are going to speak to sustainability. And then those last two questions, those are ones we use with SHRC. And again, what's helpful for this, and you might do this with whatever your project is to ask something that's open-ended, not a yes or no question, but you know, tell me how this project has helped with blank. And I always remind them, you know, the goal of SHRC was to help you guys to move towards value-based systems. Tell me how this project helped you to do that. They will talk about that. I try to capture quotes, and often those are part of the quotes that I use in the spotlights then. And it's really a good way to see that the project has lined up with our goals. And then this is just the other last question that I use with SHRC, and that is around the learning collaboratives that we do. And again, we sometimes use those as quotes. Some thoughts about wrapping up the call. I always end with, you know, is there anything else that we haven't talked about or I didn't ask you that you want to make sure I can capture? And I pause, I'm quiet, let them think about that. I remind them I can add to this at any point. I do have people often offering, hey, can I send you that those slides, or can I send you that a picture of that poster I was telling you about? Yes, absolutely. So again, I think when the wrap call is done well, people will actually offer information. They will offer more help with whatever I'm looking for. And Caleb and I were talking about this earlier, that rarely, especially after the first call, rarely do people ever avoid a wrap call, because they know it's going to be a good experience and they know that it's going to be about their success. If again, if little work was done, I always remind them, I thank you, thanks for being honest, and I'm looking forward to hearing about what happens next, and then thank them for the time and before I hang up. A couple other thoughts. I think tone of voice with RAP is really important. If I am dry, monotone, that's not going to be engaging. I need to think about it as if I'm having a conversation with them. So I need to make sure that I bring myself to the conversation and that I get excited about what they're doing, and I'm encouraging, and I'm one of their cheerleaders, so that there is that feeling that this was helpful and motivating, because if they walk away feeling inspired, then I've done my job, and it's a successful call. This is just an example of how I document RAP. This was an actual project. I always put the RAP score. Usually I have the date up there, the name of the hospital, the state. Just bullet points. I don't do a lot of narrative. I just do bullet points about their accomplishments. This was just some of this hospital's accomplishments. I wanted to fit everything on one slide. So just some short bullet points on that. Next steps, bullet points, non-measurable impact, and then how the project impacted or helped them to move forward. So again, you can see that from a real actual experience or a real hospital, they talked about more ownership for their managers, more engagement, and they're really thinking more about the possibilities and making decisions for their future. And they even said that they were thinking less about like cutting, and much more about growth and opportunity. All right, well, I am going to pause there. I know that was a lot of information, but I'm going to pause there, hand it back to Caleb for, I guess, facilitating questions, and also maybe a couple people on the line as well that have used RAP a little bit who would want to share their experiences with that. Caleb?
Yeah, absolutely. Thank you, Rhonda. Let's first open it up to questions. So please take a moment to unmute your phone with *2 and ask Rhonda any questions you might have. I don't. So one question I have, Rhonda, you talked about the difference between the conversation versus an interview. Could you expand a little bit on that and maybe just highlight the differences between an interview format and a conversation? Because I agree. I do a fair amount of these for the TASC team, and there's an important part of that is the conversation, how you're just chatting with someone and finding out about the project and how things are going. But yeah, maybe a bit more about what an interview is compared to the conversation.
Okay, sure, absolutely, good question. So I think in my mind, a conversation is less threatening. An interview feels usually more formal. People are a little bit more on guard, trying to watch what they're saying. And for me, when an interview is more about, okay, gosh, I have these 4 wrap questions. They look really nice. I'm going to go ahead and use them. And it's just going through boom, 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 and probably that's going to take 5 to 10 minutes. Whereas the conversation is using the questions as the bones of the whole process, but the back and forth and digging deeper and tell me more about this is what puts the meat on it. And I think that's what gives the story real value. I think that when, if I do a wrap and it's really short, I'm having a hard time pulling anything out of somebody, and there are times that happens. But a lot of times it's because I'm being more of an interviewer instead of digging down deeper and following their train of thought and asking for a little bit more detail here and there. So that in my mind, it's more about the flesh instead of just the bones of the 4 questions.
Yeah, I agree with that. I think that makes a whole lot of sense, and it's, I think the more of them you do, the more you appreciate that difference and start to see, oh, there's tons more stuff here if I'm talking about it with someone as opposed to asking them about it.
Yeah, exactly.
I really like to highlight the, I think as you said, the non-measurable outcomes. With so many projects, we're looking at measures and metrics and, a delta, a change in a status. But as Rhonda highlighted, if you get one team talking to another team that hasn't historically happened as much, that is a huge and beneficial outcome from any intervention or effort that the odds are that's not going to be measured on a spreadsheet. I don't know that I've put it on any spreadsheets. I'd like to hear from some of the other flex coordinators, who've utilized WRAP within their projects, within their flex programs. Do we have any volunteers?
Hi, I actually had a question for Rhonda, if that's okay.
Yeah, absolutely.
Great. This is Katie over at Colorado Rural Health Center. And I'm not really a flex coordinator, but we have been using WRAP with some of our projects, trying to do a little bit more. And I'm just wondering what you do when you spoke to us a little bit, but a little bit more about what you do when you don't have a team that's very responsive to the questions. And I feel like that sometimes happens with question 2, but especially with question 4, when we start asking about culture, they'll say, well, we really aren't there yet. And that's kind of it.
Okay, yeah, that's a good question. So, yeah, with 2, that is a little bit easier to dig down and ask for more specifics. And if they give me one thing that they did, then I ask for more detail. Well, how did you do that? Well, how'd they respond to that? And just keep it going, because sometimes as they start talking, then they'll be more open to talking even more, especially once they realize it's not such a painful conversation after all, and I'm not about to say, well, why didn't you do this? The question number 4, that piece does tend to be shorter. I do listen throughout question number 2 especially. I'm always listening for anything that is a non-measurable outcome so that I can reference it, because a lot of times that question, they have a hard time totally understanding what I'm asking about until I say, well, gosh, you mentioned that the other day you saw your leaders are beginning to go to each other and ask each other for advice. as a result of this project. So it sounds like you guys might be tearing down some silos. And they're like, oh, yeah, we are doing that. You know, and I said, oh, and I also heard you mention so-and-so, so it sounds like people are communicating a little bit more. Oh, yeah, they are doing that. So sometimes I have to feed them some things that I hear to get their, at least that primed a little bit.
Great. Okay, thank you.
Sure.
What other questions do we have?
Hey guys, this is Kayla in Kentucky. Can you hear me?
I can. How are you? Welcome.
I'm good. Thanks, Caleb. I just wanted to sort of add my input to this process and interview process. I've used this a lot, so I'm sure others on the call took part in the supplemental funding project, and as part of that, we were sort of required to do this wrap interview process, and you know, we were taught how, and I've used it like 10 plus times because we had 10 hospitals participating in the project, and it was sort of a little bit different for me because I actually did these in person, or me and someone on my team did these in person. So that was actually added an even cooler element to it, to be able to sit down in person and do this. But I really liked it because it helped keep conversations consistent. You know, we had a very sort of consistent project. I wanted to keep it consistent. We had hospitals doing a lot of similar activities, so it just sort of helped me guide that conversation with them